All right. Hello to all the Behind the Knife listeners. The Leahy team is back. Our second episode, our first Journal Club session. So once again, I'm honored to be joined by Dr. Tess Allett and Dr. Peter Marcello.
Hey, John. Happy to be back at Leahy.
Yeah, John, I'm really excited to be back. I'm looking forward to Journal Club. It's a bit different. And we had a lot of fun with the first episode, and I think this will be just as good.
Awesome. So before we get into the meat of the session, a couple of important updates. So first of all, congratulations to Tess, who graduated from colon and rectal surgery residency training. Tess, what are you up to these days?
So I'm over at UMass doing a clinical associate year, doing a lot of really awesome things. And it's been a great first few months as an attending.
Yeah, certainly you get those first weekend jitters. I did get a call from Tess with a few cases that were of interest the first weekend.
You got a couple calls.
Yeah, I got a couple. So wait a minute. So while you're over there, are you seeing anything different with Justin Makel and the crew there, what they're doing?
Yeah, we're do a lot of straight lap and a lot of TATME. So that's been really awesome to learn that new skill. So a lot of TATME, which has been great.
But don't forget to tell them about Leahy now, what we do here.
obviously.
All right, John, get us rolling.
Great. Well, congratulations once again. So we are in fact adapting to life without you here, Tess. We're excited. We have this year's colorectal fellows, Dr. Bobby Kuseko is coming to us from Thomas Jefferson in Philadelphia, and then Dr. Raghavan Siddharthan, who came to us from OHSU. So we're going to be talking about a couple journal articles related to rectal cancer. However, we did have a very good question from a listener who wanted us to elaborate a little bit on the step-up approach that we alluded to in our last episode. So the questions were specifically, are patients paralyzed for the scope, and do you give IV antibiotics? So Peter, care to clarify that for our listeners?
Sure. Yeah, no, we do this just like you do colonoscopy on a stretcher. So the patient comes in on a stretcher, they get propofol, and we do the colonoscopy, and the EMRs and ESTs are done without paralysis. Now, it does make it a little more tricky when they're breathing or coughing, but we do that. And we don't give antibiotics. If I do penetrate through the muscle, then I will give them a dose of perioperative antibiotics.
All right, great, thanks. All right, so we're very excited about this episode today. And so we're going to be presenting two articles that are very important to keep in mind when taking care of patients with rectal cancer. So the first is the RAPIDO trial, and the second is the German rectal cancer trial looking at induction versus consolidation chemotherapy. And so these are definitely trials that residents in training, practicing surgeons really should be familiar with. So we wanted to break those down for you today.
Yeah, John, before we launch into these two studies, which are tremendous, I think I want to take a step back as the old guy here and just think about the history of how did we go from where we are today in regards to treatment for rectal cancer. How do we go from doing surgery alone to now, in some cases, doing no surgery at all? And I think the important thing I want to bring back to you is when I first started in my training, pelvic recurrences were seen, and we took care of those patients. And the horrific pain they get with a pelvic recurrence, the smell of tumor coming from the perineum, and the moribund condition where they die of inanition, it really was impactful when I was young. And what I learned is you don't want to have a pelvic recurrence no matter what. So I think we just take a step back and think about that.
Yeah, and I think you'll see as we go through a lot of the trials that one of the main things that the trials focus on is local occurrence. And so that's exactly why that's important. And so for our audio listeners, just for our last episode, consider following along with our YouTube video so you can look at some of the slides and look at the articles with us as we go. So before we started using chemotherapy and radiation therapy, which are now integral treatments for rectal cancer, surgery alone was really what we started with. And so this is where you'll hear us, hear surgeons talk about the holy plane, popularized by Dr. Heald. And so Tess, let's just make a note. Let's talk a little bit about this a little bit later in the episode. Surgery alone for rectal cancer left us with very high rates of local regional recurrence. And so like Peter was saying, that's something you want to avoid. And high rates like up to 40%. So, if you've ever seen a patient like that, as Peter has, you definitely want to avoid that. We then began adding adjuvant chemotherapy and radiation therapy, but more of that started to really shift to upfront, meaning before surgery. And there are a ton of studies out there, and so we'll just sort of hit the highlights. Really the two studies that established the use of preoperative radiation therapy were the Swedish and Dutch trials. So for the Swedish trial, this compared surgery alone to preoperative radiation therapy and demonstrated that there was decreased local recurrence and improved overall survival with the use of pre-op short course. That study didn't really talk about surgical technique. The study that did, and is really the main trial that I think you hear a lot of us talk about, is the Dutch trial. And this really popularized the approach of the TME surgery. So it looked at pre-op short course radiation therapy followed by TME, total mesorectal excision, versus just surgery alone. And they did demonstrate a decrease in local recurrence with pre-op radiation therapy compared to just surgery alone. So it does decrease local recurrence, but interestingly, it doesn't show any difference in overall survival. And so that's something we'll talk about as the trials evolve.
Yeah. Hey, John, hold on a second. Just one point about this trial. Realize and remember that upper rectal cancers didn't see any benefit from pre-op radiation. And stage 1 cancers also did not see benefit from radiation. So it really was the mid to distal and the more advanced tumors that got this benefit. And that was an important point when and I was around when it first came out. But I think the most important thing here is to talk about terminology and the importance of total mesorectal excision, because when I trained, it was the hand going in and bluntly dissecting the mesorectum and leaving behind the nodal field. So Tess, can you elaborate a little bit about TME?
Sure. We have some good slides up on this. So total mesorectal excision, or TME, was popularized by Dr. Heald, and it refers to the technique that we use in resection of rectal cancer. And TME entails the use of sharp dissection of the rectum and mesorectum along the avascular plane, referred to as what we call the holy plane, outside of the rectal fascia propria, to ensure that we, with our specimen, maintain an intact mesorectum, getting all of those lymph nodes. So the goal of the TME is to excise the rectum, mesorectum, and have an intact fascial envelope.
Awesome, thanks. So next up in the evolution of these trials, we then get to the first German rectal cancer trial in 2004. And this really established giving us preoperative radiation therapy as opposed to postoperative radiation therapy. And so what that study showed us is that with pre-op radiation, you had better compliance, less toxicity, and better sphincter salvage, so less APRs. And so that really solidified the use of preoperative chemoradiation therapy. Interestingly, we rarely see a difference in overall survival between treatment regimens in some of these trials, but we do see again here that preoperative radiation therapy had lower local recurrence, which is really still critically important. And so for most of the early 2000s, we were doing long course chemoradiation therapy in the U.S., followed by surgery with the possibility of adjuvant chemotherapy.
And I just want to highlight that for many years, more than a decade, it was long course chemoradiation, surgery, and then chemotherapy post-op, and that held through the test of time, for this. And the technique of TME, it was enlightening to all of us to realize that you really need to get the fascia propria and the whole envelope removed if you wanted to have success and prevent recurrences. I will disagree a little bit with some of the study in terms of sphincter salvage, because the important point for me is that your resection should be based upon what it looked like pre-op, not what effect you got from the chemoradiation.
Yeah, so that's an important point, right? So if the tumor is something that you would need to do an APR before treatment, even if the tumor shrinks away, you should still be doing an APR, right? Is that what you're saying, Peter?
That's what I'm saying, and I still hold that true today, and I think through my career I've held to that, and I think it's important.
Right. One of the things I'll just actually throw back to you and ask a question that's always sort of bothered me with these trials is we rarely see a difference in overall survival. We just see the differences in local recurrence. Any sort of input or thoughts about why we see that with some of these trials?
Well, I think it's just the goal. Well, with some of these trials, the issue is also whether or not they're getting the adjuvant treatment, because the survival may be dictated more by the lung and the liver than the pelvis. But the truth for any colorectal surgeon is avoiding the local recurrence. We can't always control the other parts.
Got it. All right, so you're going to hear us really with these trials talking a lot about total neoadjuvant therapy. And you'll hear us talk a little bit about the term of watch and wait or non-operative management. And so this really began to gain some traction, and really the credit goes to Dr. Habergama from Brazil. And so this was her initial trial published in the Annals of Surgery in 2004, looking at non-operative management of rectal cancer, following chemoradiation therapy. And this was a really radical concept at the time.
Yeah, and I don't want to keep interjecting, but here I got to tell you something, because I remember, I can't help myself. But in 2002, Tom Reed, who's my best friend, we trained together, and I learned a lot about rectal cancer and preoperative radiotherapy, short course radiotherapy from Tom and a group at WashU in St. Louis. So shout out to that group where Dr. Abelson did his fellowship, getting us to do short course. But the concept of not operating for rectal cancer and not doing that was really foreign. And I remember Dr. Reed and Tom and I were in Rome at a meeting where they brought the people from all over the world, and Tom and I, for some reason, got invited. And I'm on a panel with Angelita Habergama, and Angelita, phenomenal person, brought up this concept. And I'm like, are you crazy? Can it really work? And we were. And I got to say, I was younger in my career, and I didn't have my eyes open. And I think you'll see now that we open our eyes fully and raise our minds to the possibility of, yes, things can change. So a huge concept, and I give her full credit for bringing this out so many years ago.
Great. Yeah, so some of her initial results showed us that in patients who have a clinical complete response to preoperative therapy, that you can actually observe these patients instead of going straight to surgery, and you can avoid the morbidity and mortality potentially associated with doing a rectal surgery. And so that sort of spawned the idea of total neoadjuvant therapy, TNT, which is a term everyone probably hears a lot about. And so, Tess, you want to just tell us a little bit more about TNT? What's that all about?
Yeah. So TNT, or total neoadjuvant treatment, is where patients for their rectal cancer get all of their treatment up front before surgery. So the proposed benefits being that patients might have better compliance, better micrometastatic disease coverage, and then better downstaging, and may allow for this watch and wait protocol.
Great. So that was a nice appetizer. So let's get into that first article. Okay, so Tess, take it away.
Yeah, so thanks. I'm going to start by breaking down the RAPIDO trial, which stands for the rectal cancer and preoperative induction therapy, followed by dedicated operation trial. So quite a mouthful. We'll stick to RAPIDO. As we've already heard about the studies establishing the role and timing for radiation therapy, the role and timing for chemotherapy in rectal cancer at the time of this study had yet to be solidified. So the main objective of the RAPIDO trial was to give chemotherapy upfront in hopes of decreasing distant metastatic disease without compromising local regional control and overall survival. So the authors hypothesized that delivering pre-op chemotherapy after radiotherapy would increase compliance, reduce distant metastatic disease, and improve survival. This was a multi-center randomized control phase 3 trial, also a mouthful. So breaking that down a bit, multiple centers participated, a total of 54, most of which were in Europe. And then Washington University was the only American site.
So yeah, so my turn to jump in. We already gave one shout out to WashU in St. Louis, and so we'll just give another one here. So where I did my training, but yes, one of the only U.S. site, and that's largely driven by the fact that that's one of the main centers in the U.S. that is routinely using short course radiation therapy, which we'll talk about a little bit more. Okay, Tess, you may resume.
All right. So this study enrolled between 2011 and 2016. 920 people were eligible and ultimately were randomized. Inclusion criteria were patients who had tumors less than 16 centimeters from the anal verge, patients with locally advanced rectal cancer, and they had to have one or more of the high-risk features based on MRI of the pelvis. So it had to be either a T4AB tumor, there had to be if there was extramural vascular invasion, N2, or positive mesorectal fascia on MRI or enlarged lateral nodes. So again, this was a randomized study. We all know on the hierarchy of study that this is at the top. Again, this was a phase 3 clinical trial. These are designed to last several years, and the purpose of phase 3 studies is to demonstrate efficacy and then also to monitor for adverse side effects. In this study, the median follow-up was 4.6 years. And then patients were randomized into either the experimental or the standard treatment groups. The experimental group received short course radiotherapy, meaning 5x5, followed by chemotherapy, either 6 cycles of Capox or 9 cycles of FOLFOX, and then they underwent TME. The standard group received traditional chemoradiation, so 28-day fractions of 1.8 gray or 25 fractions of 2 gray, followed by TME. And then the patients in the standard group got, some of them got adjuvant therapy, and this was basically depending on institutional policy. The primary outcome was 3-year disease-related treatment failure, which they defined as local regional failure, progression on treatment, distant METs, new colorectal tumor, or treatment-related death. And then secondarily, they also looked at compliance with treatment, toxicity, pathologic complete response, and then complications.
Yes, I'll just pop in for a second. We'll read a lot of these trials and we look at what they choose as their endpoints. And I always sort of wonder what's the best, what's the single best design? Maybe Peter, if you were designing your optimal trial, what would you say your primary outcome is?
Yeah, and I think, is it okay to put stuff together? I'm not sure, but I think for me, I'm still harboring on preventing local recurrence, right? And then so that's what I want to see more than anything else, is that we're going to have success in the pelvis versus survival.
All right. So in looking at the TNT experimental group, they had a statistically significant lower disease-related treatment failure with 23.7% as compared to 30% in the standard group at 3 years, which is demonstrated here. Patients in the experimental TNT group had significantly lower distant metastatic disease, 20% compared to 27% in the standard group. And there was no difference in local regional failure or overall survival. The other interesting finding was that the pathologic complete response rate was doubled in the TNT group, so 28% as compared to 14%. And they found no difference in treatment tolerance or local failure.
I think what's interesting to me about these findings is it's always nice when results sort of make sense to you. And so to me, it makes sense that if you're getting more chemotherapy, you have lower distant metastatic disease. They had no difference in local regional failure because they both had radiation therapy and surgery. So when I look at those results, I'm sort of like, yeah, that makes sense to me.
Yeah, the hard part about the studies is always, and Tess, a great overview of the study is that chemotherapy, as you said, the limitation here was optional in the standard arm. And so I'd like a trial where they're going to get everything that they're supposed to be getting. And do they get, the use of the short course in the US, not very common. So it's not going to get a lot of traction in the US because there's not many people are familiar with it, which is part of it. But I wish maybe that the timing between surgery for the control group, between the chemoradiation and surgery was shorter. We would actually probably go longer than they do. So the hard part is that every study is not quite what you do in your own institution. So you never really know, am I doing the right things? But still a huge study to show what response you can get when you give all the treatment up front, 28% versus 14%. That is tremendous.
Yeah. And so, Tess, when you were in training here, I always try to, think about it after we read a trial is what are some of your takeaway numbers so that when you're in clinic and you're advising patients about what their risks are, you have something to go back on. So what would you say are some of your takeaway numbers from this study?
Yeah, I think the bottom line here for this study is that the TNT arm demonstrated a decreased rate of treatment related failure compared to the standard, and mainly due to fewer distant metastatic disease. This approach doubled the path complete response from 28% from 14, sorry, to 28%. And so I think that's the number that really sticks with me, that, improvement in the path complete response. Again, as we kind of alluded to, this interest in organ preservation and watch and wait, this higher path complete response, I think, is really important.
Anything else to add, Peter, about this study?
No, I think that's great. So my takeaway is from this, 1 in 4, 1 in 3 people, if they do this, would get a complete clinical and pathological response. And that's huge. And that's a number that I use.
Great. All right. So the next article we thought was a nice pair to the discussion we've had so far and our focus on TNT. And so this study comes to us, again, from the German Rectal Cancer Study Group. And so we talked about that earlier in this session. So you remember that initial trial really sort of demonstrated for us that we should be giving radiation therapy before surgery rather than after surgery. So this was a randomized phase 2 trial looking at chemoradiation therapy with either chemotherapy given before radiation therapy or chemotherapy given after radiation therapy. But the idea being that it's all total neoadjuvant therapy, all for locally advanced rectal cancer. And so we know that there are clear benefits to giving all of the upfront treatments. And that's really, I think, becoming the preferred treatment paradigm, at least here at Lahey, for locally advanced rectal cancers. So the timing and the order of these treatments, I'll tell you, is something that we sort of debate every week when we're talking about patients. And so that's what this study was really trying to answer, is what is the most promising TNT sequence. And so they hypothesized that TNT should be able to increase the path CR rate up to about 25%. So again, multi-center randomized phase 2 trial. And so remember, phase 2 trials focus on efficacy and side effects. Patients had locally advanced rectal cancer within 12 centimeters from the anal verge. And surgery was indicated irrespective of tumor response. So even if a patient had clinical complete response, meaning they get all their therapy and the tumor completely melts away, they still did surgery. So the primary endpoint in this study was pathologic complete response. And I'll just say, the primary outcome for RAPIDO trial is a little confusing because they combined a bunch of things together. When you look at trial and it's like, okay, it was the pathologic complete response. That's the primary endpoint. It's a little bit easier, I think, sometimes for the reader to understand. They did have secondary outcomes like toxicity and compliance and morbidity. And so they assume that a path CR rate just with radiation therapy alone would be about 15%, but that with TNT, it should be up to 25%. And so this is a really interesting study design. It was not sort of head to head. It was just a power to select which is the better sequence. So pick the winner strategy. Wasn't powered to demonstrate a difference between the two groups at the usual significance level of 0.05. So I thought that was a very interesting study design.
And John, I'll just say, as you get to this, at least it's in a protocol which we are currently doing, A or B. And so it's easier, I think, for us in the US to look at this and say, yeah, we're going to be doing one of these. What should we do? So I'll let you go through it.
Yeah, so I really like this figure. If you're following with us again on our YouTube video. So, group A is the induction group. And so what that means is they start off with chemotherapy and then they get chemoradiation therapy. Group B is consolidation chemotherapy, meaning they start with radiation therapy and then they get chemotherapy.
Yeah. And I want to just hammer that home because I think it's really important that we understand these terms. And I agree this slide is really helpful in seeing that. So the difference between consolidation and induction chemotherapy can be a little confusing. So again, group A, which got induction chemotherapy, means that they got upfront chemotherapy with 3 cycles of FOLFOX, then they rested, then they got their chemoradiation, rested, and then had TME. Whereas group B, the consolidation group, they got chemoradiotherapy, rested, chemotherapy, rested, and then the TME.
All right. So you know what the big question here is, though? You can say no. It's okay.
No.
All right. So in your practice now, Tess, if they do induction and you then get chemoradiotherapy, when do you take them to surgery after chemoradiation? How many weeks do you wait out?
If you're doing induction, how many,
so after chemoradiation, how long do
Yeah.
you normally wait in your practice? We typically wait like 10, 12 weeks, right?
Yeah, 3 months, or 3 months.
Yeah, 3 months. So
Yeah.
10, 12 weeks.
Yeah.
In this study, they waited what? Do you know, remember? It's 6 weeks. 6 weeks.
Yeah.
So I'll just tell you, my bias of this is that you're not waiting long enough in group A to really be sure that you're getting a complete pathological response. It's not what I do in my practice.
Right.
And that's my concern about this. Group B, on the other hand, they get chemoradiation first, and then they're getting surgery how many weeks later, roughly?
12.
12. Thank you, John. So he can read and count on the slides. Tess. You can pick it up now. So all I'm saying is that group B is more like what I do in my practice. Group A is not quite it. And we'll see how that plays out. Go ahead, John.
Yeah, great. All right. So for both study groups, compliance was very high with overall treatment. And so this just sort of confirms to us that if you do chemotherapy and radiation therapy before you do a proctectomy, you're going to have much better compliance than if you do it after you do a proctectomy. Induction chemotherapy had a lower pathologic complete response at about 17% as compared to 25% for consolidation. So this really speaks to...
Boom. I just dropped the mic. Go ahead, John.
There you go. So, it's a phase 2 study. So primary endpoint was pathologic complete response. So no data on long-term clinical outcomes like disease-free survival or overall survival. Presumably that'll be coming out in the future. And they didn't include watch and wait, which is something that we're currently doing here for select patients. So it could be limited, a little bit to, how you extrapolate that to current practice.
And so I'll just say here that I think the important message here is these are tremendous results when you think about it. And it's not just clinical results, these are pathological results. And so to have a 17 to 25%, complete pathological response is tremendous, and something that I would not have imagined when I started my training or my career. And so while it's not perfect, and maybe that 17% would jump up if you'd waited another 6 weeks before you operated. We don't really know that. We'll have to wait to see long-term what happens in this group. Just tremendous results to note. Go ahead, John.
Yeah, and so I think if we're diving a little bit deeper into their protocol, so they used oxaliplatin as a radiosensitizer. So Tess, what are we using for radiosensitizing agents typically in this country?
So 5FU.
5FU, and so
yeah.
So does that make a difference using a different radiosensitizing agent? They had 3 cycles of FOLFOX, and then radiation therapy and then surgery. We're probably, if we're doing TNT, giving 6 cycles, 8 cycles. That's not totally well defined, but probably more. So are the path CR rates even higher? I mean, we don't know. So, and that's one of the things that I find very sort of intellectually curious about this, this disease process is there's so many questions, so many different pathways you can go down, which can be complicated, but I think, there's a lot of important questions to ask. All right. Anything else to add about these 2 trials?
Yeah, I think what you said was the bottom line is that, efficacy and safety, right? And that consolidation showed better compliance, and we have to wait for the final results. I think, though, that both of these studies represent landmark studies that contributing to our shift in mindset of the paradigm of treating rectal cancer and help us sort of get into a segue of how to use TNT in our practice.
Awesome. All right, so we're running out of time. And so Tess, take us home. And so give us our Tess's teaching points.
I'm glad we're sticking to this. So my main takeaways are that short course and systemic chemotherapy result in pathologic complete response of around 28%, and that compliance with multimodal therapy is going to be best with whatever initial modality is used. So if you're looking to optimize radiation therapy for locally advanced tumors, start with radiation. And if you're worried about systemic disease, then start with chemotherapy.
Awesome. Peter, Marcelo must knows. Hit
All
us.
right. The must knows come through. The rule one, though, is always going to be there every time. Trust but verify. You know, whatever's happening with the information you're getting, verify that you know what you're reading. Trust but verify. And I'm just going to go old school and say, I based my resections because I don't know how good the treatment is really going to be based upon their pre-treatment imaging and examination, and avoid local recurrences at all cost. And I think TNT is a huge benefit for this very reason. And John, why don't you bring us home with Abelson's approach?
Abelson's approach. Yeah, so a lot to unpack here, and you know, like I think I mentioned earlier in the podcast, we're still trying to look for that perfect trial to teach us how to handle each and every scenario. You know, I would say, and this is, you know, Peter sort of mentioned this, my preference is for the most part starting with radiation therapy. You know, give that radiation therapy as much time to cook the pelvis to really increase the chance that you're going to have a clinical complete response or a path complete response. So that sort of is my preference that makes the most sense to me right now, and we'll see what I say in 5 years. So once again, if you're interested in learning more about specific topics in colorectal surgery, you can join us on Sunday evenings for our colorectal surgery virtual education series. And you can also check out our show notes for details. So thanks for joining us for this journal review in colorectal surgery. We're going to see you again in March, and we're going to be talking about clinical challenges in rectal prolapse. If you enjoyed the episode, take a minute or two out of your hectic day and leave us a review. And as Behind the Knife likes to say, team, until next time,
dominate the day.
John, can we stop recording now?